Good morning, everyone. All the bigger surgeons have spoken about bigger fractures, and I'm going to focus on the smaller fractures, basically which are the avulsion fractures around the knee. Although they look subtle, there is underlying major soft tissue ligamentous injury. So if you categorize this avulsion fractures around the knee, it can be central, and in that intra-articular are ACL avulsion fractures and posterior cruciate ligament avulsion fractures. If you see extra-articularly, quadriceps avulsion fractures from the proximal pole of the patella is extremely rare, and inferior pole of the patella, that is patellar avulsion, ligamentum patellar avulsion from the inferior pole, and patellar tendon injury, tendon avulsion from the tibial tubercle is quite common in adolescent patients. In the periphery, which are very important to address because there are sigmoid fractures and arcuate fractures, and as well as there is a reverse sigmoid fracture from the medial aspect. All of us know about this anterior tibial spine avulsion fractures in adolescent kids. There is a classification, Mayers and McKeever. This is undisplaced fracture, and the second one is partially displaced with a posterior hinge, and the third one is the displaced fracture. It can be external or internal rotated, and the last one is comminuted fracture. So the treatment is basically straightforward. If it is undisplaced fracture, then always the treatment is conservative, and type 2 we can try close reduction and immobilize, but if required we can go ahead with the surgical, and in surgical again, if the fragment is large, we can fix it with the compression screw. It can be arthroscopy assisted or mini open, and type 3 and 4, especially if they are comminuted, then we'll have to go ahead with the pull out tunnel technique, that is either 2 tunnel or single tunnel or central single tunnel. So if you see in this is ACL avulsion is fixed with a mini open arthroscopy assisted CC screw fixation, and here you can see it is been fixed with a pull out suture single tunnel technique. Again, in the PCL avulsion there are 3 types. Type 1 is undisplaced, type 2 is displaced. If we can see the fracture fragment above this tibial plateau level, that means the displacement is about 10 millimeters, and that is the indication of a surgical fixation. There are different types of fixation. We can go ahead with the open reduction and internal fixation, that is a posterior medial or a central approach, or if the fragments are comminuted, and then the option is ideal option will be arthroscopic fixation, but few surgeons will prefer even as displaced with the bigger fragments also. They will go ahead with a double. This is a suture bridge 2 tunnel technique where this is fixed. The base of the PCL ligament is fixed fixed with the knots taking around the base of the PCL, and this suture bridge is taken through the tunnel so that there is a compression at the fracture site. If we get an acutely injured adolescent knee patient, it is very painful and is difficult to evaluate clinically, then the most important thing is a lateral X-ray where we can see this patella is patella alta. It is high riding patella, and if you see a fracture fragment there is an avulsion fracture. Either it has to be from the inferior pole of the patella or from the tubercle. In this case, it is a sleeve avulsion from the inferior pole of the patella. In the tibial tuberosity avulsion fracture classification, it was mentioned by Watson-Jones and modified by Ogden. It is only apophyseal fracture is a type 1. Fracture line passes through the physis in a type 2, and this is extra-articular, and in the last one is the intra-articular where the fracture line goes in the intra-articular level. So, and Ogden has classified this again, and it's a comminuted B, then type 2 comminuted and type 3 comminuted. So the treatment in this case would be fixation of the fragments. If the fragments are bigger, we can fix this with the cannulated cancellous screws, and this is a hybrid fixation where these trans-osseous sutures were taken, and along with the knotless suture anchor was used. So sleeve avulsion fractures of the inferior pole patella are seen in 10 to 16 years of age group. clinical examination again is difficult, so the diagnosis has to be on the lateral X-ray as well as the MRI. You can see a fragment floating there. So if in the inferior pole patella fracture, the fragment is usually very small. So we have two options: either excision of the fragment and patella tendon reconstruction, or we can fix it with the transosseous sutures or with the suture anchors. So usually the treatment options for the larger fragment are extra-articular cancellous screw, intra-articular we can fix with the screw or mini open or arthroscopic, and smaller fragments which is usually transosseous sutures. So quadriceps avulsion is extremely rare. It is seen in rugby and football players, and the transosseous suture technique is the ideal for that. So my focus is on the Sigon fracture, which is the anterolateral avulsion fracture of the anterolateral ligament here. This is subtle sign of the underlying anterolateral complex injury, which is very important to look. We should not overlook this sign because it gives idea about the underlying ACL and anterolateral complex injury. Reverse Sigon is also seen, which is on the medial aspect from the MCL avulsion from the tibial plateau, and it gives idea about the underlying PCL and medial meniscus tearing. Sigon fracture should not be missed because it gives, it was Paul Sigon who mentioned it in a cadaveric study, and there are a lot of studies mentioning that this is underlying anterolateral complex injury, and we should not be overlooked, and is not isolated, is usually along with the anterior cruciate ligament as well as anterolateral injury. So what if Sigon sign is seen? We have to go. We have to see Lachman's test properly if it is more than 10 millimeter and with a soft endpoint, that is type 3, grade 3B soft, grade 3B. Then we have to anticipate the anterolateral instability, and in that pivot shift is also very important to understand the anterolateral instability. So this is the case. 17 a male came with this ACL injury along with Sigon's chip fracture, and this is clinical. Examination under anesthesia, you can see this type 3B, grossly positive along with the soft endpoint. And if you see his pivot, it is, even I'm not external rotating it, there is a subluxation of the anterolateral part of the tibia. And in this case, we went ahead and we did arthroscopic ACL reconstruction, and this is the lateral incision for the lateral extra-articular tenodesis. You can see this is 10 millimeter by 80 millimeter strip of IT band taken from the posterior 1/3, and it is passed under this fibular collateral ligament, and it is sutured over itself in around 60 to 70 degree flexion with neutral rotation, so that this is called tenodesis effect. This is called as a modified McIntosh technique, and this is the closure of the IT band defect, so that it gives additional tenodesis effect there. So if you see this, these tunnels are well placed, and this is the incision for the lateral extra-articular tenodesis. Even fibular collateral avulsion fractures, these are arcuate sign. This is suggestive of a PLC injury. So if we get a patient with this avulsion fracture, then we have to anticipate again lateral as well as posterolateral complex injury, which is very common, and along with the PCL. And we should see if the posterior traverse is more than 12 millimeters, then chances of PLC injury is up to 70%. So we can do varus stress test. If it is opening in 20 degrees of flexion, side to side difference is more than 2.7 millimeters, then it is isolated lateral collateral injury. And if it is more than that, if it is more than 4 millimeters compared to the opposite side, then there is a PLC component also along with the the entire PLC is been damaged. So if you can see this in 20 degree of flexion, I am doing a varus stress clinically, of course not stress test under, not X-rays taken, but still if you compare, this is grossly opening on the lateral side, this is more than 10 millimeter opening compared to the other side. Of course I checked on the normal side as well. So this is suggestive of lateral collateral as well as posterolateral corner injury. And dial test is important to again confirm that there is a posterolateral corner injury, 90 degree of flexion. If you rotate this foot, it has to be more than 15 degrees of external rotation, so that we can call it as a posterolateral complex injury. So bone bruise, this is the recent article by Laprade. If you see this anterior bone bruising in the medial femoral condyle and medial tibial condyle, there are chances in this situation, there are 90% chances that there is avulsion of the epsil from the distal end as well as popliteus avulsion. So all the distal posterolateral corner injury is seen if the bone bruise is seen on this MRI. So the treatment is always acute repair, but repair always fails in the posterolateral complex. So the ideal indication, ideal management has to be reconstruction at a later date. And there are many techniques, anatomical, non-anatomical. This is Laprard's anatomical, and in modified there are Larson's as well as modified Larson's technique. So take-home messages, we should not overlook these subtle signs. There is underlying a major injury always. If we see this avulsion fractures, and there are many associated X-rays which can be evident on X-ray and MRI scan. If grossly positive Lachman and posterior driver stress, clinical evaluation of peripheral stress is very essential, especially anterolateral complex and posterolateral ligament complex. Stress views are necessary, they give additional information, and surgical management of peripheral structures is equally important along with anterior and posterior cruciate ligament reconstruction. Thank you.